right, so now we're going to transition to our other discussion before we take our second morning break. And continuing along the lines of Cami, Mark, we have Dr. John Greenwood. John is an EM graduate or a graduate from our UM-EM program, categorical EM program here at University of Maryland. And then he did a critical care fellowship here at the University of Maryland as well. And well, unlike Mark and Cami, we could not keep John here on staff. In fact, he was recruited away to where he currently is at the University of Pennsylvania in Philadelphia. John, thanks so much for joining us here. And what we are going to talk about, or what actually you'll provide us with pearls on, is essentially the crashing PE patient. So a critical condition that often can result in shock. We're going to hear about cardiogenic shock on the other side of our second morning break. But in words that Dr. Mathieu has taught us so often, the patient with a PE can be that clean kill. So resuscitating the patient with shock due to right-sided failure or PE, some really potential disastrous pitfalls can occur. So Dr. Greenwood, thanks for joining us here at our symposium. So great to have you. Can't wait to hear about these pitfalls we need to avoid and the pearls in resuscitating these patients.
Awesome. Thank you, Michael. I'm just going to share my screen real fast. Share. All right. All right, everyone. So thank you for having me. Thank you, Mike Winters, Michael Bond, Amol. This is just a wonderful opportunity to be able to come back and talk at University of Maryland in this shock symposium. So we're going to talk a little bit about resuscitating the right ventricle. And as Mike said, this can be from a number of different diagnoses, if you will. PE obviously being the one that is most resonating with emergency physicians. But what we're going to talk about too is some other causes of right ventricular failure. And we're going to go through a little bit about how to, one, recognize it. And then once you've identified that it's a problem and that's why your patient's crashing, what to do about it. Now, I have no disclosures. We do have an educational website that we started as fellows at Maryland in our critical care fellowship, the critical care project. And I'm fortunate enough to spend regular time with Mike Winters, Rob Rodriguez, and Peter W. on the CCPM podcast, but I have no financial disclosures to talk about. So goals for this morning, over the next 30 minutes, we're going to talk about the idea that resuscitating right ventricular failure, we're going to flip your brain around, and it actually reverses everything I think you thought you knew about resuscitation for cardiogenic shock or left heart failure. We're going to identify patients that are high risk for hemodynamic collapse from acute pulmonary hypertension, and then discuss some management strategies here. So when people talk about pulmonary hypertension or acute, I think a lot of times we talk about exacerbations of chronic PH. So there's a number of groups 1 through 5 that you may, if you read a book, you might hear about. That like classically described as pulmonary arterial hypertension, chronic PH from PEs, and then a few autoimmune and other causes. The most common ones that we see, though, in the emergency department are group 2 and 3. So these are patients who come in with acute left heart failure, CHF exacerbations, or maybe they carry a diagnosis of interstitial lung disease or COPD, these chronic hypoxemic patients, who then, when they get sick, their pulmonary pressures go up, which causes a strain on the back pressure on the right ventricle. And so when we see them, they're pretty sick. And it's not only these chronic diseases that cause increases in your pulmonary circulation pressure or pulmonary vascular resistance. Things like pulmonary edema, volume overload, hypercapnia, acidosis, hypoxemia, ARDS. Even in COVID ARDS, we've seen a lot of right ventricular dysfunction. And if you think about this, it really comes down to understanding one simple concept, that if with hypoxemia, our body's natural response is to shunt blood to places where oxygenation can improve, and we get vasoconstriction. Also, in hypercapnia, we can see, particularly with the lungs, as the acidosis gets worse, we get vasoconstriction. And if that is all happening inside the lungs, well, what happens? Well, that back pressure leads to strain on the right ventricle, kind of similarly to what we see in hypertensive emergency, right? If our systemic vascular resistance goes up, well, where does the strain go? Well, the first place is to the left ventricle. So that's why the right ventricle is so susceptible to compromise in these acute physiologic states and acute illness. And so we see some of these diseases actually pretty much every shift. So if we're looking out for right ventricular failure, I guarantee you're going to find it. But we have to know where to look and how to diagnose it. And here's the problem, is that not only do patients who are acutely ill develop worsening right ventricular dysfunction, secondary to increases in their pulmonary vascular resistance, there are interventions that we do on our patients quite commonly, such as intubation and mechanical ventilation, that can exacerbate the PA pressures even more if we don't prescribe the settings in an appropriate way. So this is going to be really important to understand how can we avoid complications for this patient who's already high risk because of their underlying disease, and basically hemodynamic collapse from interventions that they might need to get them through their acute illness. And why does mechanical ventilation cause increases in pulmonary vascular resistance? Well, think about it like this conceptually, right? All of our alveoli are surrounded by small little blood vessels involved in gas exchange, right? And so if we increase or inappropriately prescribe our mechanical ventilation, what can happen to our alveoli? We always worry about alveolar overdistension. And what happens as those alveoli get big to those perialveolar vessels? Well, they can get constricted. And so they get clamped down and compressed, which then compounds the PVR even further. And so it's really important that we are practicing things like low tidal volume ventilation and looking at things like driving pressure to make sure that we are distributing the volume of airflow to the lungs efficiently or effectively, rather than overdistending areas that can lead to worsening alveolar compression, increase in PVR, and lead to right ventricular dysfunction. So that's a really important concept here that we're going to talk about in just a minute. But why is the right ventricle so susceptible to small changes in pulmonary vascular resistance? Well, there's some anatomic reasons for that. And one of them is just the nature of how the cardiac myofilaments are even just organized, right? So this is a cool little image of how the cardiac fibers are oriented in the heart. And, not taking you back to anatomy here, but basically, if you take a look here, you'll notice a couple of really interesting things. So the left ventricle, right? The fibers are designed to be concentric and also vertical. So they are wrapped around this thick-walled structure. And that's designed this way, partly because the systemic vascular resistance, right, like our blood pressure, generally is somewhere around 120/60. There's a high afterload that left ventricle needs to overcome. Now, if we take a look at the right ventricle here, you can see that, look, it's actually really thin-walled, right? The fibers are moving in a direction that's almost helical. So they're wrapped around the left ventricle. But the design here is that, well, I just have to be efficient. And so if you were to make the analogy of the left ventricle as the bodybuilder, the right ventricle is the marathon runner. It's really designed to work efficiently. It's designed to move volume through a low pressure system, which is generally what the pulmonary arterial circulation is. It's a low pressure system to get to the left ventricle. It's thin-walled, compliant, and efficient. But the motion's a little bit different. Now, if you think about this, and we'll go through some ultrasounds in a minute, but the left ventricle, when you image it, right, what's the movement? Well, it's actually contracting, and you see this AP type movement, right? It's a compression, the lateral and the septal wall come together, and that's how the left ventricle works. Those circular fibers are constricting together. But if you take a look at the right ventricle, it moves a little bit more differently because those fibers are wrapped around in like that helical kind of orientation, the right ventricle twists and moves up in this helical motion. And that's important to remember when we're doing evaluation of the right ventricle for dysfunction. Now, because it's thin-walled, the first change that you see in a patient who has right ventricular dysfunction, it's not actually like a low EF, what you would think about on the left side, right? It's actually dilation. So the first adaptation to high afterload of the right ventricle is that the right ventricle will stretch and dilate. And this is something I think we're all comfortable with, because when we evaluate a patient for PE, right, what's the thing that we're looking for first? It's that ratio of RV to LV size to be 1:1. We were never taught to look at function. We were taught to look at size. And that's because that's the first sign of danger, is that right ventricle will start to dilate and basically become similar in size to the left ventricle if there's RV dysfunction. But unfortunately, as we start to dilate more, what happens? Well, as that right ventricle dilates, you can imagine that tricuspid annulus will start to dilate as well. We start seeing tricuspid regurgitation, right? So that's when we start seeing TR, and you might see that in Doppler with color change and reflux back up into the IVC or the SVC or IJs. If you take a look at the patient's neck veins, you might see they're super distended, and that's because that tricuspid valve is stretched out so much that it's compromised. And as that right ventricle ejects, that it's basically acting as a pop-off valve. It's no longer going solely through the pulmonary artery, but coming back up through the tricuspid valve. And that's when the patient gets into real trouble. Well, let's take a look in maybe a way that it's not just conceptual, but that we can apply this at the bedside. So RV mechanics, this is a simple apical 4-chamber view. I think we're all comfortable in taking a look at this. This is a normal sized right ventricle, about 1/3 of the size of the left ventricle. But if you notice, right, you can see the septum here is moving close to the free wall on the left ventricle here. On the right ventricle, what are we noticing? Well, if you look at that tricuspid annulus, it's really starting to bounce up and down, right? And this is showing good vertical movement. And then that free wall's moving, septum's kind of staying put there. This is perfect. This is a normal, healthy patient right here. But take that echocardiogram and let's think about what happens when we have an increase in afterload, right? Left ventricle, right? We see hypertensive patients come into the ED. Well, the stroke volume doesn't change all that much with the left ventricle with an increase in afterload. Here's a nice little experiment that was published back in 2005 that looked at changes in stroke volume with changes in afterload on the left versus the right. And so on the left, we're looking at our changes in mean arterial pressure. You'll notice the stroke volume doesn't change all that much with a 30% increase in MAT. But let's take a look and dive over to the right ventricle and what happens there with a little bit of change in PA pressures, right? So in this experiment, basically what they did was they increased the mean PA pressures from simply 15, which would be normal, to 30. And what happened to the stroke volume, right? All of a sudden, that right ventricle was trying to eject, but dropped by 30%. And you can imagine over time, right, if that happens for 30 minutes, right, the compounding effect of a reduced stroke volume of over 30%, what happens to that right ventricle? Well, it will start retaining 30% of volume, which will make it dilate. And then we start getting into trouble where it starts impinging on the left ventricle itself, right? So as that stroke volume drops, that right ventricle starts to dilate more. And if you think about the pericardium, right, it's a pretty rigid structure acutely. And just like in the head, you know, you're always taught, there's only a couple things that can exist inside the skull: blood, brain, and CSF. Well, the same thing goes for the pericardium, right? Like there's heart tissue and blood. And so, if you start to dilate one chamber, well, the other one has to shrink. And that's where we start getting reductions in our cardiac output, because the left ventricle is decreasing in volume, which leads to decreased stroke volume. Our heart rate will start to go up to try to maintain cardiac output. But over time, this can lead to a pretty significant collapse. And so this is what we're going to try to prevent here. Okay, so that's some of the mechanical problems. But what are some other things we need to think about when we're trying to address right ventricular failure? Well, this is an angiogram of basically a heart, right? And if we flip this around, right, we can take a look at how vascular each chamber of the heart is. And specifically looking at the left side, right, there's a lot of small little perfusing vessels. It's well vascularized, and it needs to be because of how much muscle the left ventricle actually requires, right? It needs a lot of blood flow. The right ventricle, on the other hand, remember, it's really thin walled, right? So the RCA is what feeds the right ventricle for the most part. And if we take a look at the density of capillaries here, or coronary vessels, it's a lot less. So changes in coronary perfusion pressure have a profound impact on right ventricular function and oxygen delivery. And so it's really important as we think about resuscitating the patient with right ventricular failure that we recognize that hypotension is really important here to address, because as that mean arterial pressure comes down, if that CVP is coming up because we're getting a dilated right ventricle, our coronary perfusion pressure is going to go down even further. And so making sure that that patient doesn't get hypotension or hypotensive is vital. Because ultimately, this is what we're really trying to avoid here. Most of us have heard in some way, shape, or form of this, kind of cardiac cycle of death, but ultimately, we just walk through it step by step. Whereas as we get increase in RV afterload, we get right ventricular dilation that leads to volume overload, which leads to impingement upon the left ventricle, which leads to decreased left-sided stroke volume, decreased cardiac output, hypotension, and ultimately poor coronary perfusion, which leads to RV ischemia and worsening function. But I think in the ED, RV dysfunction is sometimes this mythical object that we don't really think about all that much, but we've identified some patient groups that are maybe higher risk for right ventricular dysfunction. So if a patient's starting to get hypotensive and they're presenting with maybe a disease like acute hypoxemia, or we've just intubated them and the patient becomes hypotensive, but they have ARDS, maybe we should be thinking a little bit more about, what side of the heart should I actually be treating? And there's often some clues that are presented to us, whether or not from a tech who just did an EKG or with that ultrasound that's sitting right next to the bedside, that we can key in on to make some really important therapeutic decisions as we're taking care of this unstable patient. So this might be that initial EKG that you took a look at for that patient who comes in. Maybe they have a COPD exacerbation, but there's signs on here that you're like, oh, wait a second, I recognize this pattern. I think that could this patient have maybe a PE, right? So some signs that you might see, right? This S1Q3T3 pattern. We've been taught to think about PE, but really all that's telling us is it's a sign of right ventricular strain. And maybe there are some other things, right? Like a dominant R wave in V1 or an R to S ratio greater than 1. Maybe you're seeing a new incomplete right bundle branch block. Those are all signs of right ventricular dysfunction, not necessarily diagnostic for PE, right? Like the most common EKG finding for PE, tachycardia, right? But, the concerning cause of tachycardia is if our cardiac output's down because our stroke volume has reduced because that right ventricle has gotten bigger. And that tachycardia is what's keeping our cardiac output up. That's how I kind of think about it, right? So we need to be really careful about identifying these signs on our EKG. In this patient here, there's even some ST depressions in our precordial leads and into our lateral leads that might suggest, there could be some early signs of RV ischemia here. So these are really important. And not only that, but so this patient here isn't just having signs of RV strain, but there's another arrhythmia going on. I don't see many P waves here, and my concern would be as if I counted this out, mapped it out as a regular, that this was, atrial fibrillation. And atrial fibrillation happens in these patients for a specific reason. Often it's because as that tricuspid valve dilates, that annulus dilates, that right atrium starts to stretch, what can lead to atrial fibrillation. And in these patients, that atrial kick is super important. And oftentimes you can see an EKG with atrial fibrillation. What's maybe the first thought? Well, maybe I can just rate control this patient, right? Maybe we need to just slow them down, and that's why they're that's why they're maybe looking a little bit punky. But in this case, certainly I would not want to rate control this patient with right ventricular dysfunction, because that's a compensatory response. So avoiding rate control in these patients with RV dysfunction is really, really important. And in fact, my first step would be to consider something like a rhythm control drug if I was going to use anything like amiodarone, or even consider early defibrillation if there's any signs of instability, because that atrial kick really is important to help maintain the patient's cardiac output and end organ perfusion. So while the EKG is helpful, shout out to Amal, that the echocardiogram is really where I go to decide what to do next. So let's take a look at a few of these here. So this is our normal apical 4-chamber view. This is an example of a 24-year-old with a history of primary pulmonary hypertension, acute shortness of breath. Here you're starting to notice a couple of key figures here: a dilated right atrium, likely because that tricuspid annulus is dilated, a really large right ventricle that's impinging on the left ventricle. This is a patient with clear right ventricular dysfunction, right? And if we rotate 90 degrees, get into a short chamber view, notice this dilated right ventricle with some chronic changes here in the thick RV, but certainly signs of trouble are staring us right in the face. But that's a chronic patient, right? This is an acute patient. This is a patient who presented to the emergency department with ARDS, right? So was intubated, mechanically ventilated. But what are we seeing here? This patient had a marginal blood pressure. Well, all of a sudden, we're seeing the septal bowing pushing into the left ventricle, a dilated, actually, it looks like both atria are dilated, probably has some chronic diastolic dysfunction, but certainly signs of right ventricular strain are going on right in front of us. So this might be a patient that we really need to approach a little bit differently. This is a 72-year-old after intubation, I believe, has had a COPD exacerbation. Again, dilated right ventricle, dilated right atrium, small left ventricle, did not have a PE. In fact, was from acute hypoxemia, had an increase in his PVR. So we've identified this. How do we diagnose our right ventricular dysfunction? Well, aside from size, right, we can actually have an objective measure of RV strain, and that's through something called a TAPSE. So this is a really simple measurement to do. If you're doing ultrasounds on baby or kind of fetal heart tones, and you know how to use M mode, you can do a TAPSE and quantify how bad the patient's RV strain is. So this is, as I mentioned before, the importance of the lateral annulus of the tricuspid valve. If you can get that apical 4-chamber view and put your M mode cursor down within 20 degrees of center, you can measure that vertical movement of the tricuspid valve, which will help you understand, okay, where am I at? How severe is this patient's dysfunction? If you measure that vertical movement, and this is after we've put in M mode, we can see that wave form that comes up on the screen. If that vertical movement is less than a centimeter, your patient is in real trouble. And we need to start resuscitating that patient quickly, as opposed to just kind of sitting on it and watching it. So how do we do that? Well, like I said, we're going to reverse how we often think about resuscitating the patient, oftentimes with septic shock, who might come into the ED, and kind of do some things that are the opposite. And all of us, I think, are comfortable with this idea of tank pump and pipes, right? To what are some of my hemodynamic targets that I'm going to try to accomplish or address in the next 30 minutes of my resuscitation. So when we think about the tank, right, for the patient with right ventricular failure, we're really thinking about volume status, right? So in fact, what we want to do is contract that volume status as opposed to expand it in patients with like vasodilatory shock, for example. When we talk about the pump, well, we've already learned how we can assess the right ventricular function with ultrasound. And also we want to feed it. So we want to maintain coronary perfusion by addressing blood pressure pretty aggressively. And lastly, how do we reverse that clamping down of the pulmonary vascular resistance? Well, we want to unload the right ventricle and think about how we can reduce the PVR. So let's talk about that a little bit. So we just intubated this patient with a COPD exacerbation, and we've echoed them because they're a little bit hypotensive, and we've identified RV dysfunction, right? I think most of the time, hypotension after intubation, the first step is to give fluids, right? Because, oh, it's just the medications that are causing some vasodilatation. And sometimes we might even see something like this, right? So this is, as we're looking at dynamic measures of volume responsiveness, we see that wavy arterial line up on the monitor, think, oh, look, they're volume responsive, right? They have significant pulse pressure variation. But I want you to think about that for a second. Why would this patient look like they're volume responsive in RV failure? Well, if you remember back, that left ventricle is now squished down, right? Of course, it's going to look like it's volume responsive because it is underfilled. But that's only because that right ventricle is now impinging on the space of the left ventricle and it can't fill. So in fact, this is a common pitfall, is to look for things like our classic volume responsiveness techniques. This is actually a red flag for me. If they're looking more volume responsive, it means that my left ventricular function has gotten even worse. And so I need to unload the right ventricle even more. Now, oftentimes we might hear, oh, the CVP is dead. Well, it's not. At least not in right ventricular failure. It's a pretty significant marker for RV dysfunction, right? So if we're ultrasounding, we see a dilated IVC in a patient with RV dysfunction, that usually, and if it's not moving at all, it's plethoric. That usually means the CVP is high, probably in this red zone greater than 14. So we have to figure out how to unload that and how to reduce the volume here. This was a cool little trial that was just published called, lovingly the diaper trial. But what they did was they looked at over 300 patients with a QPE with a SPESI score greater than 1, so heart rate greater than 110, a slightly low systolic blood pressure, and desaturating to less than 90%. And they asked the simple question: if we give them an early dose of Lasix, right? And these patients all had right ventricular dysfunction. Can we normalize the SPESI at 24 hours? And that's not something we usually do in the ED, is early Lasix for PE. But in fact, what they found was there was a significant improvement of the primary outcome of a normalized SPESI in the diuretics group. So what they're getting at is they worked on unloading the right ventricle by contracting down, reducing the patient's volume status, so that right ventricle could kind of contract down and start getting back on its normal Starling curve. So this is a nice little trial of idea of, oh, maybe we should be diuresing our patients with a QPE and RV dysfunction early on. Okay, so we talked about volume contraction, reducing the CVP. How do we address this pump function? Well, if you remember back, the RCA really is a weak perfuser. And in fact, it perfuses the RV during systole and diastole. So we need to focus on how we can improve coronary perfusion. And remember, CPP is very simple. It's just basically your diastolic blood pressure minus your CVP. So how can we increase our diastolic blood pressure and reduce our CVP to make that gradient higher? Well, we can do that with drugs, right? So simple vasopressors. So if that patient's hypotensive, addressing it early with a vasopressor like vasopressin or norepinephrine. Norepinephrine gives you a little bit of benefit because it gives you some inotropic support as well. And addressing that CVP, well, in some cases, you may even consider just adding on epi, right? Because that gives you alpha and beta. It gives your right ventricle some more inotropic support. We use a lot of inodilators like milrinone up in the ICU. But if you're not comfortable with that, that's totally fine. But basically getting some sort of vasopressor or inotropic support on to support that right ventricle is going to help improve right ventricular output and reduce your CVP and move blood from right to left. Okay, so this gets back to our patient we just intubated, clearly is in trouble. Our TAPC is less than 1 here. So we got some work to do. And again, remember, less than 1 severe dysfunction needs to be addressed. So we've addressed the tank. We're not giving volume. We may even be giving diuretics early. We've addressed the squeeze of the right ventricle with some sort of inotropic support. We've brought that patient's blood pressure up to improve our coronary perfusion. But how do we unload the right ventricle? We got to drop the afterload, which is really addressing the pulmonary vascular resistance. And there's some acute reversibles that we can fix in the ED, right? Reversing hypoxemia, addressing their COPD exacerbation, fixing their metabolic acidosis will help reduce the PVR. But what if we still have that, TAPC less than 1? What else can we use? Well, I think it's worth having a conversation with our pharmacist or a hospital pharmacy group if we're outside of an academic institution. The idea of inhaled epoprostenol has really been shown to improve pulmonary vascular resistance and right ventricular dysfunction in the literature. And while INO is kind of a pain to get a hold of, inhaled Flolan or epoprostenol is actually quite simple to start. You basically start it at a fixed dose and you leave it. Those side effects there's really no systemic side effects to worry about. And if you can get your respiratory therapist on board, you can deliver it through high flow nasal cannula. And again, probably something to discuss before you get that acute patient into the ED, but something that's definitely changed our practice. We used inhaled epoprostenol in the ED via high flow nasal cannula all the time. And it can also be delivered through the normal mechanical ventilator. So, something to kind of discuss, to think about what other adjunctive treatments can we use to reduce the RV afterload and improve our RV dysfunction in that patient who's crashing in front of us. All right, so final points here. Right ventricular dysfunction and acute pulmonary hypertension is actually quite common in the ED. But it really takes a little bit of a nuanced physician to really look out for it. So bring your ultrasound to the bedside early. Practice your TAPC. It's really easy to do. You have all the skills to do it already. It's just putting them together outside of the uterus and bring it up to the mediastinum. And certainly in that patient who's hypotensive, reduce the urge to give volume up front. You can try a small 250 fluid challenge, but if they're not responding or they're looking even more volume responsive after you give it, you got to reverse course. Turn that ship around and start thinking about how to unload the right ventricle, which is maybe a little bit different than what we're used to. So with that, this is my email. Please feel free to email me if you have any questions. This is my Twitter. And certainly, I know Mike Winters talked about this before, but, support the right ventricle, but also support our communities that are going through trouble, some really challenging times right now. My thoughts are, and hopefully my actions are supporting the families down in Texas and across the country right now. So thank you.
Thanks so much, John. That was outstanding. Really, really helpful pearls that you discussed in terms of resuscitating the RV. So well done. My thanks. We are actually...